Healthcare, and having enough doctors. We need doctors, right? It's one of the biggest issues in our system is having enough doctors. And there is, something that is forcing doctors out of the public system into the private system. Get a load of this. More than 500 Quebec doctors have left the public system to practice privately. Let's try and find out why so many are doing that. What can be done to sort of change that, to turn that tide around? We go to Dr. Laura Sang, a family doctor right here in Montreal, who joins us. Dr. Sang, welcome back to the program.
Hi, thank you for having me.
So you're a family doctor. You're in the public system?
Yes, I am.
Maybe I should ask, how often do you consider leaving the public system, or do you?
I mean, I'm super happy with where I work. It's challenging, it's stimulating, but at the same time, I'm still always looking for that work-life balance that, is often eluding me.
So what do you think? What do you think's going on there, on here? When it comes to getting that work-life balance, do you think there's just a lot of doctors when they weigh, their current work situation and look at, with the grass being greener on the other side, they're making this determination? Tell me about that, what you're seeing.
So I think just to contextualize things, I'd like to just briefly explain how things work in the public system. So any physician that works in the public system is held to two things, a PREM and an AMP. A PREM is the region that you're assigned to that you have to practice within, and the AMP is a series of specific medical activities that you have to do to meet certain requirements, and that's 12 hours a week. Usually they're mixed, so you have to do some sort of what we call prise en charge, so an office-based practice, seeing your patients as one would expect in clinic, and then 6 hours of something else, which could be long-term care facility, hospitalist, etc. So when you have 12 hours a week that is dictated for you, you have to work in the rest of your scheduling around that. And what becomes challenging is if I want to have, for example, a lot of walk-in spots for my patients, there's 2 days a week that I can't because I'm working elsewhere. And simultaneously, all the days that I'm at clinic, my patients have to be looked after by someone else during my absence. So it can be a little bit more challenging to try to manage both of those spheres when you have these restrictions in place. Originally, the PREMs and the AMPs were put in place to try to make sure that all the needs within the province were filled and that doctors were distributed evenly and where there was the greatest need. How that's evolved over time is something that I think can be called into question. And I think that allowing more flexibility within the AMPs and within the PREMs and providing incentives instead of penalties would make the public system much more appealing to work in.
So what would that flexibility look like that would lead to better outcomes for patients, for better services for patients? How would that flexibility lead to better outcomes?
So I think in terms of flexibility, instead of being very, the AMPs are very rigid. If you want to switch AMPs, that's a discussion that has to happen with your specific region. And usually when you sign on for an AMP, that's a 2-year contract that can be renewed every 2 years, or you can switch AMPs. I know that, people have their strengths and they have their niches and they want to be able to work within those. So I think that trying to, work with physicians and figure out what they want to do. Do most people prefer to practice in one area versus two? Where are the areas that people are looking to go towards? What kind of incentives can we put in place to, fill areas that are maybe less interesting to certain physicians, either because it's outside of their scope or their area of interest? But I think trying to put people where they enjoy their work and where they're good at it is always a good strategy because people will have a higher job satisfaction. And if they can control that aspect, then you have some more control over your hours and, how you want to divvy up your time.
Yeah, and I can see how that could bring a lot of certainty to the network, right? And stability to the network when you've got people that are happy with what they're doing. I just want to juxtapose for a second, Dr. Sang. We're with Dr. Laura Sang, a family doctor in Montreal, and we're talking about why so many doctors in the province have left the public system for the private system. I know healthcare is not perfect anywhere in this country, and I've seen the stories coming out of other provinces that sometimes you say, geez, it seems like it's better in Quebec than some other places right now in certain metrics, in certain aspects. But I want to ask you what sets Quebec apart here, because my understanding is this type of exodus from public to private isn't happening in other provinces because it's not even allowed in other provinces. Can you tell us a little bit more on that end? What sets Quebec apart?
So I think that, we all know that Quebec is in a very unique political position, and that, a lot of those sort of contextual factors outside of the healthcare system can certainly have an effect. I know that this PREM AMP system doesn't exist in other provinces. So there is nothing, so to speak, to switch from. In Quebec. I'm not sure about for other provinces, but in Quebec, if you are working in the public system, you cannot work in the private system. You cannot work in both. It's one or the other. And there is a limit on the number of times that you can switch. So I think that's something that, could be a contributing factor. And I think that what we also need is just sort of more transparency on the data and comparing the trends that are happening over time to give us a better and clearer idea of why this is happening. I think that it's just a multitude of factors, and I don't have anything specific other than that I feel like I could say without the data behind me to back it up.
Let me ask, because I know there's a whole bunch of people that are now relying on private clinics for their family medicine, right? For family medicine type of stuff. You're a family doctor. You're staying in the public system. How much of this comes down to money? And I imagine, and I'm wondering, have you ever had these thoughts where you feel you could make more money if you went over to the private system?
I mean, I think everybody's thought about it at some point, especially when, you're graduating residency and you're trying to figure out what kind of life you envision for yourself, what kind of career you envision. I think, I can't speak for everyone else, but I know for me personally that quality of life is more important to me than money. But I think that, in the private setting, I don't know what the restrictions are for charging. I think it would be really interesting to talk to somebody who works in the private sector to get a better idea of this. But I think you can set your own rates. You can, the cost of your clinic, I think, is different. I think that you just, in general, have more control over what you do, and that can be very, very appealing to some people. And I think that, especially when you're working these long 12, 16-hour days and you're thinking, my gosh, I wonder if there's another reality that I could be living right now, that sometimes more money feels like the answer. But I think what we really need to focus on is creating a healthy work environment for patients and physicians alike, so that you can have better retention and that you can work at your best and optimize the work that you do and the returns that come with that.
Dr. Sang, we have to leave it there. Thanks so much. I know you're busy. Thanks for your time.
Thank you.
That's Dr. Laura Sang, a family doctor right here in Montreal.